20 or 30 years before this conversation. So he knew a little bit of what he spoke. And I took away from that two very important points that crystallized my thoughts, ultimately culminating in the book. First of all, he had a vision. He had limited knowledge about his illness, and he had an acceptance of the inevitable. And with those three, the foundation for good decision-making can be made. And then more importantly, he taught me in an instant that if one wants to die at home, it is fundamental that someone be prepared to say no to hospitalization. And that's what we're going to talk about today. And as I said, I come at this from a slightly different perspective, maybe a more realistic, more practical point of view that's a little bit harsher, perhaps, than some authors on the subject. There was a book recently was published entitled Death for Future Corpses and the People Who Love It. And this is, we have many of the same conclusions, but my publisher would never allow me to use that title. We instead, there's another title recently published, and used also 18 years ago, that talking about death won't kill you. That's the title of it. And that will be the subject, sort of the subject of our discussion today. And I hope that it doesn't get too, there will be some sad moments for people, I'm sure, but we'll work it through. So I want to tell you another story that's not in the book. And this is a story about a woman who had septic shock. And sepsis is perhaps the most important illness that most people don't know of. And the story is not in the book because she was not my patient. And I didn't think of her until I was writing an article for the Washington Post about sepsis. Because sepsis awareness has been growing, the focus of a variety of sepsis awareness organizations is to encourage patients to go to the emergency room with their illness, and if it's not clear what's happening, to ask the emergency room physician if this is this sepsis, doctor? Because if it is, I wanted to treat it early. And I'll come back to that in a minute. I forgot to explain what sepsis is to the non-medical people. Sepsis is when an infection breaks out of the confines of the original site. So sepsis can follow pneumonia if the bacteria get out of the lungs. Urosepsis is when bacteria get out of the urinary tract and circulate in the blood. Sepsis can follow cellulitis when it escapes the confines of the skin. And bacteria circulating cause the immune system to overreact and turn against the patient and damage the patient's organs. So back to the article. The point of my article was that patients, the prognosis for elderly patients is quite different than the prognosis for younger patients. When patients were diagnosed at a young age, I'm saying less than 50, their survival rate of serious sepsis is 75%, and they have decades of life ahead of them to recover, recuperate, rejuvenate in a sense, and rehabilitate. Whereas elderly patients, the mortality rate is 60+% for septic shock, and they don't have decades of time to recover. So my point was to suggest, in the sense of sepsis awareness, that patients, young patients might go to the emergency room and ask, is this sepsis? If it is, treat me early and treat me aggressively. And elderly patients might say, doctor, if this is sepsis, please treat me, but if I deteriorate into septic shock, please consider palliative care. So the story that I want to tell is of a patient who was 86 years old, a woman, completely independent similar to my father's circumstances, and she went to her internist for her executive physical examination. And I want to tell this story because in the end it will encapsulate so many of the points I try to make in the book. She went for her physical examination with the idea that they would preempt, they would find subtle problems, analyze them, and prevent bigger problems later. The good news was her physical examination was largely normal. However, she did have a small drop in her blood count. Her red blood count was slightly lower, a mild degree of anemia. What my memory is that it was what we call a multifactorial anemia. It could have been slow bone marrow production of blood. It could have been a nutritional deficiency. It could have been blood loss. But the referring physician sent her to a gastroenterologist, my colleague for whom we cross-covered with on weekends, who, with the admonition that my colleague was not to let this woman die of colon cancer on his watch. So taking that warning, the gastroenterologist scheduled her for a variety of tests, including a colonoscopy, which was performed semi-uneventfully. Everything went well. They found one tiny blood vessel in the colon called an arteriovenous malformation, a tiny abnormality that might leak blood, but no obvious evidence of that in this case. It was cauterized, and she went home, and everybody felt good about it. The cautery destroys the blood vessel, it scars over, it heals, the weak part is gone, or is treated. She came back 2 or 3 hours later after her post-colonoscopy nap with abdominal pain and was admitted with what we call a microperforation or post-cautery syndrome. And she was admitted with the assumption she would be better in 1 or 2 days if she's put on antibiotics and intravenous fluids. Unfortunately, she did not get better, and you might guess where I'm going with this. That night she was feverish, she couldn't speak for herself, her blood pressure went down, her pain increased, she became confused, her family was called in. The family had not understood that there should be limits on her care because there were no limits placed on her care. The doctors in the family put her in the intensive care unit, and she proceeded to deteriorate despite everyone's best efforts. This is when I saw her on the occasional weekend, and 2.5 months after her admission, she was discharged, having suffered some brain damage, respiratory failure requiring weeks of intubation, hemodialysis for kidney failure, and gangrene of several extremities requiring amputations of several parts of her hands and feet. Now, I mention this story, as I said, because it encapsulates so many points I try to make, not because it's horrifying, but for the medical people in the audience. We know that things happen, things go wrong quite regularly, not usually to this degree. In my mind, it challenges the false assumption that we can prevent every problem in elderly patients and that preventive physical examinations are useful. It points out that there is a momentum to treat in medicine. When a problem is suggested, we have to chase it down. We tend not to take a wait-and-see attitude. It is easier to act than to observe. It points out that that frequently with elderly patients, it is better to do nothing or to do less than to do more, and it is almost always better to do nothing than to do too much. And it points out that once you get on the conveyor belt of medicine, it is hard to stop it, and that we tend to double down on our treatments. And that is because doctors are like generals on a battlefield. We want to address our enemy with overwhelming force, and yet it's hard to remember, but we must remember, that dying with disease and old age, or dying with old age and disease, are battles that can't be won. And where this woman's treatment went from appropriate to aggressive to excessive to futile is subject to debate. But I maintain that at some point she received futile treatment even though she survived. And I'd like to point out two definitions of futile treatment. One is academic and one is mine. The academic definition of futile treatment is treatment that a patient cannot appreciate as beneficial, that they cannot appreciate as benefiting them. And the classic illustration is a patient, a brain-dead patient on life support. But the definition I just mentioned is really much more subtle than that, because there are many things we do to patients where they don't really understand it. And we have to ask ourselves, is this really helping them, or are we just spinning our wheels? And I maintain that when this woman who lost some cognitive function would have a hard time appreciating that her amputations were truly beneficial, even though intellectually we know that they saved her life, because otherwise the gangrene would have spread. My definition is retrospective. I say that if you look back at the last treatment that your loved one endured before they passed away, and if you say, I wish I hadn't done that to my mother, or I wish they hadn't done that to my friend, that is futile treatment. And the trick is to anticipate it and avoid it. Now, there's an old medical aphorism that it is a doctor's responsibility to help patients die young, as late in life as possible. And that resonates with us because we all want to live long, vigorous lives, and we want to be healthy to the very end. But that belies the fact that if we are lucky enough to live to old age, 80% of us will not be vigorous when we die. 80% of us will be disabled if we define disability as the inability to take care of ourselves. 80% of us will be disabled during the last year of our life. Now, my father appreciated the 3 years of vigorous life that he got in return for his endovascular repair. My sisters and I prevailed on him to undergo that procedure. He did, and we prevailed on him because we wanted him to meet our grandchildren. And he did live 5 more years total and met 12 great-grandchildren. But 2 of those years were not happy years for him. He was dwindling. He was fading. He was fatigued. He did not have the energy to live the life that he wanted, and he expressed an interest in waking up dead. We couldn't help him in that regard. We didn't want to. But we did try and help him with his fatigue. We took him to his internist, who said it's not metabolic, to see the cardiologist, who saw the cardiologist, who said it's not heart failure, psychologist, who said your lymphoma is stable, that's not your cause of your fatigue, see a psychiatrist. The psychiatrist said you're not depressed, go see your internist. And after we made that cycle twice, my father said, that must have taken 12 to 14 months, my father said, enough. And when his cardiologist said for the second time, your aneurysm has re-expanded, you have to have another procedure, he said, no thank you. He's phoned all his physicians and said, thank you for your care, but I'm canceling my future appointments. I would like a palliative care consultation. And he went home and roughly 18 months later passed away, having gone into hospice about 8 months before he finally died of geriatric failure to thrive, as best we can tell. We are not allowed to use that diagnosis anymore. So how did my father know that, and that's what he wanted, and what lesson do I take from that? Well, his vision was to decline emergency surgery, take palliative medicine, and die quickly and decisively. But most of us won't have an opportunity to decline emergency surgery. But we have to think of the opportunities that we might have. Patients